Hi, my name is Dr. Diane Spatz. I am a professor of perinatal nursing at the University of Pennsylvania in Philadelphia, PA. I'm also a nurse researcher and director of the lactation program at Children's Hospital Philadelphia. I'm also the clinical coordinator of our milk bank, so I have quite a few jobs. I have been working with women and breastfeeding and human milk for the past 25 years. And so every day, not only as an educator, but as a researcher, I'm also working in clinical practice with families too. So I'm really going to be focusing on that critical window of opportunity for milk supply. And so what we know from a research standpoint is that the first hour after birth is crucial. We know that the first day, the first 2 days, the first 3 to 5 days really set the stage for long-term milk production. And so if a baby is healthy and is able to breastfeed effectively, and we know the baby's feeding well, the baby is the very best person to drive the breastfeeding relationship. Unfortunately, with current birth hospital practices, the way in which women give birth, they have very interventional deliveries. And what occurs in the birth hospital stay, the quote normal lactation experience doesn't usually occur for most mother-baby dyads. So we have mothers who have risk factors for not establishing milk supply effectively. So first-time moms, moms who are over age 30, moms who have a high body mass index of over 30. We have babies who may not have feeding behaviors like those babies who are born without the effects of Pitocin or a mother being induced, or without the effects of anesthesia. And so if our babies are separated from our mothers or they're not feeding effectively, then the breast isn't getting the sufficient stimulation really to effectively convert that mother from what we call lactogenesis 1, or making colostrum, which starts in pregnancy, to lactogenesis 2, or coming to full volume. What we need to really create, starting in pregnancy, is the sense of urgency about milk supply. Many moms come into the birth hospital and they deliver and they think that they don't have any milk. They'll say things like, I have no milk, there's no milk. But they've been making milk since 16 weeks of pregnancy. But that first milk, colostrum, has a very specialized role. And colostrum is not really meant to get a baby big and fat. It's really there for the baby's immune system. And so we have to really work on that messaging, that it's very, very normal for that baby to have small, frequent meals. The baby might breastfeed every 1 hour or every 2 hours, but that's okay. But we really need to focus on that first 3 to 5 days and ensure that the mother comes to full volume. And if there's any risk factors from the mom standpoint or the infant standpoint, besides that direct breastfeeding, we need to add on that milk expression with a hospital-grade pump so we can ensure that she comes to full volume. We have research that shows what happens in that first 3 to 5 day period not only predicts where a mother will be at 2 weeks out, but will predict where she'll be at 6 weeks out. And so in my talk today, I'm going to be really focusing on this idea or this concept of coming to volume, and how do we both assess risk, and then how do we proactively mitigate risk to ensure that we can help mothers come to full milk production so that they can go on to meet their personal breastfeeding goals. If a baby is healthy and can breastfeed, that baby should be to breast within the first hour. We know that this doesn't happen globally, okay? If the baby's unable to feed at the breast, then we need that mother to be expressing with that Symphony pump with initiation technology within that first hour, okay? And what we want families to understand is that there's a critical window of opportunity. So when I say to a new mother who is separated from her infant, I need you to express milk every 2 to 3 hours, or 8 or more sessions in a 24-hour period, I'm not asking her to do that for the rest of her life. I'm asking her to do that in that critical window during that first 2 weeks. And so helping reframe for the family that this is a time sensitive, but it's also a time bound period of time where we have to really focus on milk supply. We certainly want that baby to be skin to skin with the mother whenever feasible. So if it's a mother who has a healthy baby, but maybe breastfeeding isn't going so well, the baby maybe isn't latching effectively, that mother, when she takes her baby home, she should find a place in her house where she can kind of camp out, feel free to be topless for the first 2 weeks, and just keep her baby skin to skin and feed that baby on that baby's cues. Because the baby on her chest is going to enhance her milk making capacity, right? So mom's only job, if her baby is home with her, is that she eats, sleeps, and breastfeeds. And if we really protected that critical window of opportunity for mothers and focused on milk supply, we would probably solve a lot of the world's breastfeeding problems in terms of concern about milk supply. Globally, the #1 concern of mothers is milk supply. If a mother presents with risk factors, things like a high BMI, being a first-time mother, being a mother who's over 30, all right? These mothers, in addition to their baby breastfeeding, if their baby's able to feed at the breast, I would want to have them also add in expression sessions with a hospital-grade pump. One of the common things that happens in birth hospitals here in the UK, in the United States, around the world, is often in that short birth hospital stay, even for the healthy term babies, many infants are getting supplemented, or in the UK they often say they get topped off. And if you are going to top off a baby, if you're going to supplement a baby, that baby is going to get filled up with a supplement. The baby's not going to awake and cue to feed, and then the breasts aren't going to get stimulated, and milk supply is going to spiral downward, okay? So my message, because we call it supplementation in the United States, is if you're going to say the S word to a woman, supplement, then you need to say the P word, which is pump, okay? Because anytime we're talking about feeding a baby someplace else than at the breast, then the breasts aren't getting the stimulation, and we know we have a critical window of opportunity. Most important thing about breastfeeding, the most important thing about breastfeeding is milk supply. If you don't have milk, you're not going to be a breastfeeding mom long term. And it's interesting because yesterday I did a tea for the consumer media, and many of the writers there were also mothers. And it was fascinating because they all talked about the fact that why weren't we given this information? Why did no one talk about this during prenatal care? Why wasn't I prepared to really understand what I need to about my body's ability to make milk? And one of the participants actually had a baby there with her, and it was her first child. And she has been struggling with milk production her whole breastfeeding experience. And, you know, she said to me, I wish I would have met you 6 months ago, right? I wish I would have known you 6 months ago because my whole experience could have been different. I think it's really important to remember that as long as there are breasts present, we make milk, okay? Now, there are a couple of conditions. For example, if a mother has abnormal breast tissue development, people call it glandular hypoplasia or insufficient glandular tissue, those mothers no matter how much they breastfeed or pump, are not going to come to full volume. So we wouldn't want them expecting that they could make 100% of their baby's needs. They will make milk, but even with a mother like that, it would be about optimizing her milk supply. A mother who, for example, has had breast reduction surgery, her anatomy has been altered. So again, her milk supply can be compromised. So the message, though, in those cases is that mom is going to still make milk, okay? But how do we optimize her milk production? But for all other mothers, and, mothers who haven't had breast surgery and moms who don't have abnormal breast tissue development, for all those other mothers, if we really pay a closer attention to assessing risk antenatally, identifying that risk while they're still pregnant, and then proactively managing it. That's what's key. And I'll just give one case scenario of a mother I recently worked with. She was over 40, history of 5 years of infertility. Her body mass index was over 30, and she was going to be induced because of advanced maternal age. We did not want to have her be pregnant longer. And so I said very upfront to her, look, these are your risks. You're 42, you have a long history of infertility, you have a high body mass. We know that you're probably going to end up with an interventional delivery, which in fact she ended up with a cesarean. And I said to her, what we need to do is we need to protect and build your milk supply. So the baby was born, she was able to do skin to skin immediately and breastfeed, but I actually had the mother rent a hospital grade pump, a Symphony pump with this initiation technology, to take it to her birth hospital, because she was delivering at a hospital that, despite being baby friendly, having the baby friendly certification, I knew that they would not be on top of her milk expression. And so the nurses and the staff all looked at her. Why do you have this pump here? Why are you bringing this in? Why are you doing this? And she says, because I've talked to the world leading expert on milk supply. And so in that hospitalization, she both breastfed and expressed milk for her baby. They wanted to supplement the baby, and instead of supplementing the baby, she decided that she was going to check her and herself out of the hospital early on day 2 because she didn't want the baby to be supplemented. That mother, with the skin to skin, the breastfeeding, the pumping, she came to full volume normally. She now makes over 1 liter of milk a day.